Good evening and welcome to the Cure HHT webinar series. I am Nicole Schaefer, Director of Professional and Medical Programs for Cure HHT. Welcome to this evening's webinar, an ENT case study, Hereditary Hemorrhagic Telangiectasia. Just a few reminders, this is our first medical professional webinar. After the webinar, you will receive an email with a short survey. Please complete this so we can better serve you in the future. To help reduce background noise, everyone's phones or microphones have been muted. To ask questions throughout the webinar, go into the gray panel on your screen and type your question. We will allow as many questions as time allows during the second half of the call. I also want to make you aware that in the handout section of your control panel, you will find 5 handouts relevant to epistaxis in HHT. You may download these at any time during the webinar. Now it is my pleasure to introduce our speakers. Dr. David Poetker is a board-certified otolaryngologist at the Frederick Medical College of Wisconsin HHT Center, who specializes in all disorders of the nose and sinuses, including epistaxis. He has received specialty training at the Oregon Health and Science University, where he worked with many HHT patients, receiving valuable training in managing epistaxis. He remains very interested in epistaxis and HHT management and has authored several peer-reviewed articles on this topic. Dr. James Gossage is Director of the Pulmonary Vascular Disease Program and the HHT Center of Excellence at Augusta University. He received his medical degree from Rush Medical College, followed by a residency at Barnes Hospital and a fellowship in pulmonary and critical care medicine at Vanderbilt University. Dr. Gossage has taken care of HHT patients since 1995 and opened up his HHT Center of Excellence in 2003. In 2008, he was appointed Medical Director of the HHT Foundation, now known as Cure HHT. Dr. Gossage's research and clinical interests include HHT, pulmonary hypertension, pulmonary embolism, and right heart catheterization. I now pass tonight's program over to Dr. Poetker and Dr. Gossage.
Thank you, Nicole, and thank you to Cure HHT for inviting us to speak. This is David Poetker. I am at the Medical College of Wisconsin. I'm a ear, nose, and throat doctor and see all of our HHT patients for their epistaxis. I'm going to start the program and present the case, and then I'm going to pass the program over to Dr. Gossage, and he's going to talk a little bit more about workup and evaluation, and then I'm going to come back on the line and talk about some surgical options for HHT. So our objectives for the evening are to learn to recognize HHT, to learn medical options for epistaxis, discuss surgical options for epistaxis, and review additional screening measures for our HHT patients. So we'll start with a case. I have a 57-year-old man who comes in with epistaxis. This has been a lifelong issue, but it's been significantly worse over the past 3 years. He says both sides will bleed. There's really no preference or laterality. He gets several bleeds per week, and he says these bleeds range anywhere from a drip to a gush, and on average last about 5 minutes or so. As most HHT patients have, he has an elaborate method for stopping the bleeds with various types of clamps and packing and materials that he uses. His past medical history is pretty non-significant. He's got no history of anemia, liver disease, hemophilia. He's not on any anticoagulation. He's never had any transfusions for anemia secondary to the bleeds, and he's never seen an ear, nose, and throat doctor or been to the emergency room and had his nose manipulated or any nasal surgeries. Of note, he does have a family history of epistaxis. And so when we see him, and we look in his nose, this is what we see. Now the question that I have for the audience is whether or not this is HHT. And for this individual picture, I'm not sure that I would jump to HHT regardless of the history. We can see one pretty prominent vessel on the left side of his anterior septum, but we don't see the characteristic telangiectasias that we normally see with our HHT patients. Now, converse to the first picture, this is a second patient, and I think this is far more characteristic of an HHT patient. You can see the telangiectasias on the septum, the inferior turbinate, one even on the middle turbinate, and on the floor of the nose. Much more characteristic of an HHT patient. And then the final picture that I have for you is probably someone who has pretty severe HHT, and these look to me more like an arteriovenous malformation rather than the telangiectasias in the prior picture. So with this, I'm going to pass it over to Dr. Gossage, and he's going to talk about what we do now when we have this patient sitting in our clinic. Jim, go ahead.
Hi, I'm Jim Gossage. I run the HHT Center at the Augusta University in Augusta, Georgia. I'm a pulmonologist, and I work together with our ENT down here, Dr. Alan Whitehouse. And at least at our center, Alan does all the surgical management of HHT-related epistaxis, whereas I take care of the medical management. That's what I'm going to speak to you about today, is the medical management, and also a little bit about any additional testing or screening that should be done on these patients, referrals, and some medical therapies. Next slide. So in terms of pathology, HHT is a problem of increased angiogenesis, increased blood vessel formation. You can see telangiectasias, which we see in the nose, and which David showed some nice pictures of. And these can be in many different places, the mouth, the fingers, the GI tract. And typically these are anywhere from 1 millimeter or 2 to maybe up to 5 or 6 millimeters in diameter. Arteriovenous malformations may also be seen, but those are most commonly seen in the solid organs, liver, in the brain, in the lungs, and AV fistula also. The problem is that these telangiectasias and AVMs have thin vessel walls, which leads to mucosal fragility, and in the case of nasal telangiectasias, any type of trauma, even insignificant trauma, can cause epistaxis. Just blowing the nose, turning over in bed at night, all of these things can lead to a nosebleed. This is said to be the most common disease of vascular structures that leads to recurrent epistaxis. And I think it's important to understand that HHT is a blood vessel, a vascular disorder. It's not really, it's not a coagulopathy. There's nothing wrong with the clotting system. It's more a vessel fragility issue. Next slide. And the main culprit here, at least so far as we understand, is vascular endothelial growth factor, or VEGF. It's the key pathogenic factor in HHT. If we look at the 3 main genetic mutations that result in HHT, these are all lesions in the transforming growth factor beta, or TGF-beta pathway. It's a little bit unclear how, but through one mechanism or another, these mutations lead to higher levels of VEGF in the blood and the tissues, which leads to excessive blood vessel formation, and typically in AVMs at least, loss of capillaries. Next slide. In terms of the diagnosis of HHT, these are based on the so-called Curacao criteria. These were named this way because a number of HHT researchers met on the island of Curacao, I think about 1998. They were having some drinks after one of the meeting at the beach and came up with these criteria. May sound a little bit loose, but these really have stood the test of time and very clearly do a good job to separate out those who do and don't have HHT. So there's 4 criteria. First criterion is epistaxis, spontaneous and recurrent. And it's not really any better defined in the criteria than spontaneous and recurrent, but spontaneous is a key part of the definition. And also some recent data suggests that about 2 nosebleeds per month would, in general, qualify for as a positive criteria here. So if you just have a person who's got 1 nosebleed a year, 1 nosebleed every couple of years, while they're in the shower blowing their nose, that really wouldn't meet the criteria. Whereas if they're having a couple nosebleeds a month or a couple nosebleeds a day, with some of these being spontaneous or nocturnal, that would meet that criterion. Then the second criterion are mucocutaneous telangiectasias at characteristic sites. These include fingertips, hands, lips, tongue, face, and ears. There are other things that can cause telangiectasias, and scleroderma or crest syndrome is a not uncommon cause of telangiectasias. But I don't think I've ever seen a person with scleroderma who had telangiectasias on the tongue. So tongue, fingertips are good hints that this patient may have HHT, especially if they have many of the telangiectasias. Third criterion is a first-degree relative with the diagnosis of HHT according to these criteria. We'll come back to that. And one of the points I want to make about the mucocutaneous telangiectasias is that these typically are developing in the third or fourth decade of life. So if you're seeing a 20-year-old who has nosebleeds but no telangiectasias, they may not have those telangiectasias yet, but will likely get them when they're 30 or 40. Now they can occur even as children, but more commonly they're beginning about 10 to 15 years after the nosebleeds have started. And then the last criterion are the visceral arteriovenous malformations, especially in the lungs, liver, brain. So if a patient has one of these four criteria, we would say that they're unlikely to have HHT. If they have two criteria, we would consider it possible or suspected HHT. And if they have three or more of these criteria, that would be a definite diagnosis of HHT. That's pretty solid. If you meet all three of these criteria, the specificity is excellent for that diagnosis. Now, one caveat here is that if you kind of think about this carefully, you realize that in order to be able to use the family history as one of the four criteria for a patient who's maybe sitting in your office, there has to be someone in that family tree who has a definite diagnosis by these criteria, which if they're going to be the person who you're using to cinch your family history, they have to have epistaxis, telangiectasias, and visceral AVMs. So there has to be somebody in the family history who has all three of these in order to use family history. And once you've established that person, so maybe it's the grandfather, then that grandfather can be family history for the mother. The mother is then family history for the child that you see in your office. I hope that makes sense, but that someone in the family history has to have arteriovenous malformations in order to have a positive family history. Next slide. So in terms of working patients up, bubble echo is a very important part of that workup. It's just a transthoracic contrast echocardiogram with agitated saline injection. This has excellent sensitivity, and it has very little risk to injecting bubbles here. That's compared to a CT scan or pulmonary angiography. So its sensitivity is excellent, but its specificity in terms of finding macroscopic AVMs that might be seen in a CT scan or are treatable by pulmonary angiography is not as good. And this is done simply by putting an IV in. You inject agitated saline, which has microbubbles in it. You're monitoring the right and left heart, typically in a 4-chamber view by echo. And when this agitated saline is injected, it looks like a snowstorm filling up the right side of the heart as it comes in through the systemic veins. In the normal healthy person, these bubbles would be completely captured by the capillaries, and you would see nothing get over to the left side of the heart. In the case of a patient with arteriovenous malformations in the lung, you see bubbles getting over to the left side of the heart. That would be a positive test, which would suggest that they've got arteriovenous malformations in the lung. And these should go on, you should then go on and confirm these with the chest CT to see if they have AVMs that are large enough to be treated. I think one of the problems that we have known about for a long time in HHT is if we look, and there have been a few research studies that have looked at this, that when patients first presented to a physician with symptoms of HHT, whether it's a nosebleed or a stroke from a lung AVM, it is many years, sometimes 20 to 30 years before the patient actually gets the diagnosis of HHT. And so this is the key place where ENT physicians can come in, because you all are one of the most common physicians or caregivers that an HHT patient will first see, because nosebleeds are an early part of their disease. And it's critical that you not only treat their nosebleeds, but also consider the diagnosis of HHT. And if you do believe they have HHT, it's what commonly happens, whether it's emergency room or an ENT physician, is they take care of the problem, tell the patient they've got HHT, and then they're on their own. But it's really of utmost importance that you refer this patient either for additional screening, which I'll continue to talk about in just a moment, or get them into an HHT center so that they can get additional screening, get the family members screened. On average, 1/2 of children from an HHT parent will end up having HHT. So it's pretty common in the family. Next slide, please. Next slide. In terms of additional testing that we recommend, we like to look for brain AVMs with an MRI brain with gadolinium. If there's a concern about anemia, you can get a CBC and a ferritin level. One of the gold standards is DNA testing, if it's available, if it's covered by insurance. About 85% of HHT families will have an identifiable mutation by 2017 technology. And that's critical because if you test them and they're positive for an HHT mutation, then that result and that testing can be done on other people in the family, uncles, nieces, siblings, children, with 100% accuracy in identifying who does and who doesn't have HHT. So it's critical, and the people we focus on are the immediate family, parents, siblings, and children in terms of additional screening. If DNA is not available, or if the DNA test was done but it's negative, then we're left with clinical screening, which includes the MRI and the echo and a physical examination by somebody who knows what to look for in HHT. And at the bottom, a variety of referrals for interventional radiology to fix brain AVMs or lung AVMs, GI consults for gastrointestinal bleeding. In general, we recommend that most people end up going to an HHT Center of Excellence if possible. It's the easiest place to get all of these tests coordinated. So as practitioners, if you see these patients, at a minimum, please refer them to an HHT center, or if there's not one nearby, then these are some of the tests that you can order, at least to get the ball rolling, to make sure that they don't have any occult AVMs in important organs. Next slide. Okay, so this is a paper version of what we call the Epistaxis Severity Score, or ESS. This was developed by a pulmonologist by the name of Jeff Hogue out at Johns Hopkins. He's now at Drexel, and this can be accessed through the Drexel website. And it involves asking 6 questions, and there's anywhere from 2 to 6 responses, as you can see here. And let's just walk through our patient that David presented earlier to figure out the ESS here. So the first one is, how often do you typically have nose bleeding? And I believe that it was several per week. And so that would be the 4th one down, which would give a score of 3, which would be plugged into the calculator. In terms of the second question, how long do the nosebleeds last? It was 5 minutes. So that would be the second response, which would equal a 1. We'll say that this patient typically was not gushing, although some were gushing, but we'll say typically we're not gushing. So that'd be a 0. Since the patient is in your office today for a nosebleed, we'll say that they have sought medical attention. That'd be a yes. They're not anemic and they haven't received blood transfusions, so those would both be no's. And if you do the calculations, and this is just done simply by plugging this information in, and the calculator will do it automatically, then you get an ESS of 3.51. Next slide. And this is the mild moderate severity rating. The ESS that will come out will be somewhere between 0 and 10. And a 3.51 would qualify in the mild end of that scale. Next slide. This is something that we use in research studies and even in clinical practice to help us determine, is whatever we're doing, is this being a benefit to the patient? These are some of the treatment options that's discussed in the paper that I believe was downloaded to the website by Nathan Sauter, an ENT who used to be in Oregon Health Sciences but has moved on. I'm not sure where. Anyway, so this patient has mild epistaxis, and in general, I think that the best option for somebody like this, a nosebleed a week, a couple nosebleeds a week, not lasting too long, would be topical treatment if possible. These are some of in the top half of this table, some of the options that we have. Tranexamic acid gel. Tranexamic acid is an antifibrinolytic agent that can help stabilize clots. Its efficacy, at least the efficacy for gel, is not well established. One of the papers that is included in the download to the website is what we call the NOSE study, North American Study of Epistaxis, which was conducted at our center and 5 other centers in North America, and was a randomized study in 120 patients of a tranexamic acid spray, a bevacizumab spray, an estrogen spray, and a saline or placebo spray. And what we found was that tranexamic acid spray really was no better than saline. So that's something that I've used in the past. I've stopped using it based on those data. Whether a tranexamic acid gel would work any better, because perhaps it adheres better, we don't know. There's no real good research there. So it's something you might use, but I think we can say that just a standard tranexamic acid spray is probably not efficacious. Next one down is an estrogen cream. And in the study, we also look at an estrogen spray in the methylcellulose base, but it's fairly thin, and no doubt a good bit of this was going down the back of the throat and in the stomach. This also fared no better than saline in this study. So spray, I think, is out. Cream and ointment, I think there are some data, no good randomized controlled data, but something you could consider. But to be honest, I think that really the first agents I'm trying nowadays, if it's just topicals where I'm starting with, is going to be either saline spray or simple Vaseline. A little dab 2 or 3 times a day. I know that some people are worried that Vaseline will cause lipoid pneumonia. I think that's more for people who are just packing their nostrils with it. I think if you're just applying a very light coating on the fingertip or at the end of a Q-tip to each nostril, I've probably used this on a good 80 patients and have never had anybody with lipoid pneumonia. Moving down, you pierce an ointment. No really good data for it. It's an antibiotic. It might help if somebody has some local inflammation that is contributing to their nose bleeding, but we don't have great data to go forward with that. Then we have bevacizumab spray. And again, this research study that we have given you a copy of looked at a low-dose bevacizumab spray and found, again, no better than saline spray. I've changed my own practice. I have used a good bit of bevacizumab spray. It was unclear to me how well it was working, but I think the data show that at this dose, it probably does not work. I've now switched to a 21 milligram per ml gel spray, which is in a Mucilax mucoadhesive polymer. It sticks to the mucosa better. It seems to be working in about 40 to 50% of patients, but that's just based on anecdotal data. So I would be trying in this particular patient, I would try either Vaseline 2 or 3 times a day or saline spray 3, 4, 5, 6 times a day. I think both are very safe, and with mild epistaxis, a good number of patients will get a benefit. That may be all they need. Next slide. So at this point, I will turn this back over to David.
All right. Thanks, Jim. So as the question is posed, what if these fail? So what if they don't get as good of response from the topical medications as we would like? Well, there are surgical options and many surgical options that remain. There are various forms of cautery, and I think with the current audience, I don't have to explain these in too much detail, but a lot of people like silver nitrate. It is a chemical cautery. It destroys tissue. The problem that I have seen with this isn't so much in the ENT population, but a little bit more in the urgent care or emergency room population. And I think it does destroy tissue, and it's very easy to cause a lot of tissue damage unknowingly or unintentionally with the silver nitrate. There's always the concern of silver tattooing and those sorts of things as well. And I actually have seen septal perforations with excessive silver nitrate use. I would say that it's probably effective, and in my experience, it's been effective probably 40 to 50% of the time. It's a little bit less effective, I think, in HHT patients. And again, if you get one of the telangiectasias bleeding, then it washes away the chemical, and it doesn't really do anything. The next option is the monopolar electrosurgery or monopolar cautery or the BOVI. This passes electrical current through the tissue to a grounding pad on the body. What it does is you're not heating the tip of the instrument, you're heating the tissues with the electricity. And by heating the tissues, that's cauterizing those tissues. The problem with the monopolar is the amount of heat that is generated with that electricity. The more heat you have, the more tissue damage there is. The more tissue damage there is, the more new blood vessels that grow into the area of treatment. And with the higher levels of VEGF and the issues with HHT patients to begin with, I think what you really want to do is you want to minimize the tissue damage. You want to minimize the amount of new blood vessels that grow in there, and I think that slows down the recurrence rate of the telangiectasias. Bipolar is the next option, and as most of you know, that just passes electricity between the tips of the device. The beauty of the bipolar is, again, it's less heat than the monopolar. Less heat leads to less tissue damage. You are able to cauterize those telangiectasias without causing as much collateral damage of the tissue. This has been studied. This was studied at the Center of Excellence at Oregon Health Sciences University. They published their results on 18 patients that underwent 42 different treatments. They found no septal perforations, no synechia formation, and these patients had pretty good control of epistaxis compared to what they were doing before. And what they were doing before is a combination of monopolar laser treatments, those sorts of things. I think this study predated the Epistaxis severity score, so they weren't able to use that as a metric for the results of this study. This is a video of using a Stamberger bipolar in the nose, middle turbinate here. There's a telangiectasia. And what you can see is you just put that on either side. You usually put it on about 15 or 20 watts. And ideally, I wouldn't have cooked it so long that it actually exploded there. You just want to blanch that area. And by blanching that cauterizes the telangiectasia and helps that scar down. The laser, a lot of people like the laser. A lot of people are very fond of the laser. I've actually gotten away from using the laser. I don't even have laser privileges any longer. The commonly used wavelengths are the KTP or 532. A lot of people use the YAG laser and the argon laser. The problem that I found with the laser is several things. One, it's cumbersome. With the safety glasses, with those wavelengths, they are red tinted lenses, so you can't see the telangiectasias as well. You can't see where the aiming laser is. Delivering it, you have to deliver the laser beams at a 90-degree angle to the nasal passage, and that's very difficult. And then it's also expensive. So our institution doesn't own its own laser. We have to rent it, and with that, you are renting the person who's running the laser, and so that adds about a couple $1,000s to any surgical procedure when I do it at my institution. So getting back to the cumbersome nature of the laser, here's a picture. we're looking in the patient's left nares. You can see that there's a large septal perforation, and you can see telangiectasias that have been treated throughout the septum and on the right inferior turbinate, and here's a little bit on the left inferior turbinate. If you put on your laser safety glasses, this is the view that you get. You can't see the various shades of red as well, and so what I find myself doing when I'm trying to use the laser, or what I've found myself in the past, is lifting up the laser safety glasses to try to see where I want to shoot the laser, and then putting it back down and firing the laser. Very cumbersome. So that's one of the reasons why I've gotten away from it. What I've gone to almost exclusively now is the coblation. Coblation stands for cold ablation. Many of you are probably more familiar with this with a tonsillectomy or a turbinate reduction. But it basically passes electricity through saline, ionizing that saline, and that creates a plasma field. The beauty of the coblation is that it's much lower temperatures. It's only about 60 degrees centigrade, which is far lower than even the bipolar. And with that, you produce a much more superficial burn. You have a lot less tissue damage, and I think that works a lot better and provides a better duration of benefit for these patients. Here is a video you can see on the right side, or just see the tip of the coblation wand. Here's a telangiectasia here. This is one that has been treated. What you can see is the wand comes in. Now this is a ProCize EZ View, P-R-O-C-I-Z-E, EZ View wand. And here's another on the other side. You can see the telangiectasia and a very superficial burn of that telangiectasia. Here's another one of a telangiectasia on a middle turbinate. Pass the wand, get the saline flowing, and then you're left with just a very superficial burn on that. That heals very quickly. It crusts very little, and again, it provides a longer duration of benefit. Here's a before and after. You can see the telangiectasias on the septum and the inferior turbinate there, and this is afterwards. A lot of blanching, but really pretty superficial as far as the burn is concerned. Moving on to septodermoplasty, this is an older procedure, and many of you may have far more experience with this than I do. Basically, the idea is to use a curette to remove the mucous membrane of the septum down to the perichondrium. You then take a split thickness skin graft, usually from the thigh, and lay that over the perichondrium and sew that in place. This is what it looks like afterwards. You can see the graft here. Now, frequently what happens with this is you have a really big graft in there, but that graft will contract. And at the periphery of the graft, you can see telangiectasias growing. The other thing that can happen is that telangiectasias can grow underneath the graft, and that's just acting as a barrier to prevent those from drying out and bleeding. The people who are good at it are very good at it and report some very effective results on that. Again, some downsides with that is there is grafting from the leg. You do lose the normal mucociliary clearance from the nose, so the patients get a lot of crusting, and so you have to get them to irrigate and moisturize the nose aggressively. Those telangiectasias, as I mentioned, can form underneath, and then frequently that graft will contract and telangiectasias form at the border of the graft, leading to more bleeding. Sclerotherapy. Sclerotherapy has been championed by a few people around the around the country. Basically, the idea is to inject a sclerosing agent into the vessels themselves. That leads to a lot of inflammation. That inflammation is followed by fibrosis, and so essentially that telangiectasia scars off. And so it's similar to varicose veins or something along those lines. Holly Boyer from the University of Minnesota, she's done a lot of this, perhaps more than anybody else in the country, and they reported their series. This was in IFAR in 2015. They looked at 17 patients between 2011 and 2014. And it was a crossover design. Basically, they compared the Epistaxis severity score with the patient's prior therapy, whatever that was, irrigations, topical therapies, simple cautery, and then they compared it with sclerotherapy. And again, they used the Epistaxis severity score as the main outcome measure. And what they found was that there's a significant improvement in the severity score after the sclerotherapy when compared to the prior therapy. So if the patient was getting Cautery, then the sclerotherapy worked better than the Cautery. If they were using a topical ointment, then the sclerotherapy worked better than the topical ointment. Jay Piccirillo, and I got these slides from Jay, he has used the sodium Sotradecol sulfate as a sclerosing agent, or Sotradecol, and he reported his series over 5 years. He had 58 patients that received 234 procedures overall. He didn't necessarily in these slides report his success rate. However, he did have some complications that he talks about. The majority had no complications. There were 3 septal perforations. He had 1 patient that lost vision in one eye following an injection, and he had 1 patient that went vasovagal, another patient with a persistent headache. Now, as you can imagine, having that unilateral vision loss, that shook him up quite a bit. And so what he did is he actually spent some time with Dr. Boyer in Minnesota and learned a better technique of mixing the Sotradecol. And since he has learned this newer technique, he's not had any complications and no further issues with unilateral vision loss. And interestingly enough, Jay tells the story that when he warns patients about the risk of blindness, they all gladly accept that risk because they have had such good results with this sclerotherapy. So this is just a slide of the treatment options. You have access to this in one of the handouts. This comes from the article by Nathan Sauter and Tim Smith from Oregon. It is downloadable on the control panel that you have access to, and it basically lists the various procedures that I talked about: the laser, coblation, bipolar, mucosal injection of the bevacizumab or the Avastin, sclerotherapy, septodermoplasty. Young's procedure I didn't talk about, but that's basically sewing the nostril shut, and this is really reserved for people with life-threatening epistaxis. So not usually the kind of thing that most of us will see. So with that, I'm going to turn this over to Jim again real quick, and he's going to talk about a couple other medical treatments for our HHT patients. Jim?
Thanks, David. Okay, so before I get to other medical treatments, I do want to say a word or two about the Young's procedure. And at most places that typically have done the septodermoplasties as kind of the final treatment when all else fails, I think most of those places have switched over to Young's procedure. It sounds draconian, but it really works. And the vast majority of the patients that we've had, we've probably done it in 15 patients so far, say, you know, I wish I had made the decision to get this done earlier. It's completely changed my life. And these are people whose nosebleeds they're going on all day long. They're getting blood, you know, 1 couple units a week. So their life is completely consumed with nosebleeds. And this fixes it. In fact, we had one guy who we closed. He said, this is great, but I can't smell anymore. Open me back up again. We opened him back up again. And 2 weeks later, he says, close me up. Because the nosebleeds came back, and it was just such a big problem in his life that he just decided that no nosebleeds was better than no smell. So I think it is helpful, but in a very limited number of patients. I agree with David there. So in terms of other medical treatments, these are mostly used for people that are in the moderate and sometimes severe range. We have N-acetylcysteine, which is an antioxidant. It's over-the-counter, has essentially no side effects. There's a little bit of research suggesting it helps. How much it helps, I'm not sure. I don't use a lot of it, but some of the other centers do. So it's something to consider because it's easy to use. Then we've got tranexamic acid and aminocaproic acid orally. These are taken orally, and these are antifibrinolytic agents which help stabilize clots. And at least for tranexamic acid, there are 2 randomized controlled studies that show benefit. And I would say it probably helps about 50% of people. Probably doesn't stop the bleeds in most people, but it can make a dramatic decrease in some people. So I think it is worth trying if you've run out of other things to do. Doxycycline has been used. It has some anti-inflammatory properties. It's an antibiotic. It may also affect metalloproteases. There's not a lot of data on this, just really some anecdotal experience. I have not personally used it, but it's another option that is fairly low risk. I mentioned earlier the bevacizumab spray in the Mucilax mucoadhesive polymer. I think this does help people. And I've got some people who order it up about every 9 to 12 months, and basically their nosebleeds go away completely. The problem is it's usually not covered by insurance, and it costs about $900 for a course, and that course typically lasts for 4 to 9 months in terms of the benefit. Then we've got a variety of hormones, estrogen, standard birth control pills, tamoxifen and raloxifene. These can be used in both women and men, although more typically in women. And not a lot of data. There are some data to suggest they help, and I do have people on these, but they, of all the things we have here, besides the intravenous bevacizumab, these are the ones most associated with side effects. So that's a little bit further down in my list of things to do. And then finally, when nothing else is working, we have intravenous bevacizumab in chemotherapy doses, 5 milligrams per kilogram every 2 weeks for 6 doses. And it works in most people, but again, it's a chemotherapy and has its own set of side effects. In terms of how you might, as ENT physicians, might use these medical therapies, you're probably not going to want to get into hormones or chemotherapy, but certainly tranexamic acid, N-acetylcysteine, these are fairly benign for the most part, so something that you could reasonably use. Bevacizumab is easy enough to use, essentially no side effects, but you'd have to get the prescription right and find a place that can fill the prescription for you. It's a compounded medication. If it's something you're interested in, feel free to shoot me an email and I can set you up with more information about that. I think that's it. Next slide, please. Thank you.
Great. Well, thank you, Dr. Poetker and Dr. Gossage, for presenting 2 challenging cases and definitely giving us a lot of information about how to manage and treat HHT epistaxis. Before we start the question and answer period, I want to remind everyone that there are 5 handouts that you can download from the handout section of your panel. And we will be forwarding to everyone some information along with a flash drive with some of these documents on them as well. So the first question we have is, how well do the medical therapies really work?
Okay, so I guess I'll take that one. Medical therapies. I would say that none of these work in 100% of people. I think it depends on the severity of the nosebleeds, other medical problems, and just that person's own HHT profile. Unfortunately, for most of these, we don't really have good predictors. But I think that in people who get very mild nosebleeds, I think that things like Vaseline and saline work to some degree in, let's say, 50% of people, but probably don't do much for the people with more moderate or severe nosebleeds. And again, for most of these, it's important to differentiate working from stopping the nosebleeds completely. I tell people when I see them in my office that we can help people with their nosebleeds in almost 100% of cases. It may take some trial and error, but occasionally the nosebleeds will go away. If you have a laser, for example, the nosebleeds might go away completely for several months and then slowly start to come back again. I think things like the tranexamic acid probably work in 30 to 50% of people. Again, a clinically significant improvement, but usually don't make the nosebleeds go away completely. But to be honest, most patients are happy with a 50% reduction in a nosebleed. That can be a big help to their quality of life.
Okay, great. Thank you. Our next question is, do you have any advice for doctors starting tranexamic acid in HHT patients to reduce risk of venous thromboembolism?
So it turns out that, when people think of tranexamic acid, it's an antifibrinolytic agent, and we think about it as causing clots. Well, it really doesn't cause clots. What it does is it stabilizes clots. So if you have somebody who does not have an inherent risk for clotting, it probably isn't going to do much to cause clotting. We had our scientific meeting in Captiva, Florida in 2015, and we had a workshop, and there were probably 50 HHT experts from around the world there, and we talked about the management of nosebleeds. And I was not a big user of tranexamic acid at that time, but I queried the audience as to how many people have seen, because of my worry about thromboembolic disease, and I queried the audience, and nobody in the audience had ever seen a thromboembolic complication in an HHT patient. So I've used quite a bit of it since then with good success and have not seen any thromboembolic complications. So I think the key thing is you want to use the smallest dose possible. I start out at a bigger dose and work my way back. It needs to be given 3 times a day. You want to avoid people with obvious risks for thromboembolic disease. So if they have a history of DVT or PE unprovoked, I would not give those patients tranexamic acid. If they've got atrial fibrillation and are not on aspirin or something, I would not give that patient tranexamic acid. Malignancy, I'd think about that one. I'm not sure if I would give it or not, but I wouldn't necessarily exclude it out of hand. So avoid obvious thromboembolic risk factors and try to get the lowest dose possible.
Okay, thank you. The next question is, what is your approach to clinical screening in young children who are asymptomatic and where genetic testing is not available?
Okay, so the main worry about kids is that they harbor an asymptomatic brain AVM. Probably about 8% of patients with HHT have brain AVMs. They can be seen in utero. I probably got 7 or 8 families that have had a child who had an intracranial hemorrhage in the first year of life from an undiagnosed brain AVM. So our most important thing is to get an MRI of the brain in the first 6 months of life if possible, to make sure they don't have a brain that needs to be treated. In terms of pulmonary AVMs, we usually don't screen for those until about age 10 to 14, simply because unless they have symptoms like blue fingers or shortness of breath, they don't tend to cause complications in children. It's more the adults that get the complications. So we focus more on symptomatic lung AVMs in the kids. No screening for liver AVMs, no screening for GI AVMs in that population. So main focus in kids is to look for brain AVMs.
I'm sorry, so the next question I think is more for Dr. Poetker. How should epistaxis be treated in children, and are there any differences in the approach?
I don't think there are too many differences in approach. I would I approach my pediatric epistaxis patients the same way, and my pediatric HHT patients. Now I have far fewer patients that are kids that have problems with epistaxis. But if they do, I try the topical medications. I try the humidification, saline mist, the saline gel. I think those are very important. I don't use the Vaseline as much. I like the mupirocin a little bit better. The mupirocin is a polyethylene glycol based, so it's water soluble, and that's been shown to be a little bit healthier for the nasal mucosa. You don't get absorption of the oils, and so you don't get what's called myelospherulosis in there. So so I like the mupirocin a little bit better. I have no idea if the antibiotic has any role in it or not. I've tried to get the polyethylene glycol ointment alone, and it's expensive and difficult to make, so it's a lot cheaper and easier to just give them the mupirocin ointment. But I think that that's a good option, and again, even if they were the 1 in a million that aspirated the mupirocin, it doesn't. It's water soluble, so you don't have to worry about a chemical pneumonitis or the lipid pneumonia like Dr. Gossage had mentioned. If I am going to take them to the OR, then I try really hard to be as gentle as possible. So the Coblation wand, I mentioned the ProSize Easy View. I set it at 4/4, so 4 for Coblation and 4 for bipolar, and try very hard to be as gentle as possible. It's a difficult thing to use in kids that are probably younger than about 10 or 11 years of age because their nostrils are so small. But if you can get at them, then that's a good way to go about doing it, as opposed to, like I said, the laser or definitely not a monopolar. So just as gentle as possible and as conservative as possible with the kids.
Okay, thank you. So do you ever ask patients if they have identified any food triggers, such as spicy foods or particular foods that help or contribute to their nosebleeds?
I don't. Usually they know that and they will volunteer that, but that usually doesn't provide me much clinical information. So that's not one of my typical questions for them.
Okay. And if
let me just chime in there. I get a lot of patients ask me that question. Are there any foods they should avoid? And I tell them that each person is different. A minority of people notice a worsening of nosebleeds after alcohol. Could be beer, could be red wine. It seems to be idiosyncratic. Occasional persons are bothered by spicy things. But I just tell them, if you take it and it makes your nose bleed, don't eat it. But there's really nothing that is uniformly bad for patients. So I agree with David. I don't really get into that history with them, but if they ask me, I'll tell them if it makes you feel bad, don't eat it.
Okay. If nosebleeds get worse during pregnancy, how should these be treated?
We're pretty limited during pregnancy. A lot of times what I will tell my patients, whether it's my HHT patients or it's my sinusitis patients, when they're pregnant, there's just not much that we can do. It's not worth risking the health of the baby. A lot of times things can be done in the clinic. If there's one area in particular that's bleeding, well then you can use we have a little jeweler's bipolar in the clinic, and with a very small amount of topical lidocaine and local anesthetic, you can cauterize that. But usually if it's bad, unless there's some issue with such severe nosebleeds that they're anemic and that that's putting them at risk or the baby at risk, then I usually try to do as little as I possibly can while they're pregnant.
Okay, great. Thank you. And what advice do you give to patients about how to stop acute nosebleeds?
I don't usually give them too much advice. They usually give me advice, and I give our Epistaxis lecture to our ER residents, and I have a whole section on HHT and what I usually tell the ER residents is that HHT patients have forgotten more about stopping nosebleeds than any of us will ever know. And it's really true. People, they know what works for them. I will share some of the things that other patients have told me, whether it be something like a quick clot. I have one patient who grinds up the tranexamic acid tablets, and he uses that as a powder in his nose. There's a lot of different things, and they all have their little tips and tricks, but usually by the time they've come and seen me, they know how to stop their nosebleeds. So it's more of a question of telling other people. So one thing that I think works pretty well, actually, coincidentally, one of my HHT patients called just before this webinar and was going into the emergency room. So I called the emergency room doctor and I mentioned what I have done, and sometimes dissolvable packing. I like the chitosan-based packing, and some of you may be familiar with Posicep, or there's a new one. It's not Nasopore, it's Hemopore. Those are both chitosan-based. They are absorbable, so you don't have to worry about taking them back out. It's not like a rhino rocket that you have to pull out and worry about trauma as you're pulling them back out. A sublabial injection of some local with 1 to 100,000 epinephrine works remarkably well, because a lot of these anterior bleeds are fed by the labial artery. So I just do a upper gingival buccal sulcus injection of some local anesthetic, and that provides a dramatic response and helps cut down the bleeds quite a bit. So there are little things like that I will share with other providers that may encounter them, but I don't usually have too much advice for the patients themselves.
Okay.
David, I had a lady once who had bad nosebleeds, and she would go to the dollar store and buy all of their super glue every couple of weeks, and she would put super glue in her nose.
That sounds awful.
Not one I would recommend.
Yeah, no, I don't think I'd recommend that one either.
Neither would I. So do you think that nasal allergies make HHT nosebleeds worse? And do you use nasal steroids in these patients?
So I think they make yes and no. I think that the allergies can make the nosebleeds worse if they're doing a lot of nose blowing. That will clearly make the nosebleeds worse. If they have a lot of congestion, that actually can make some of the bleeds better because they're getting less airflow through their nose. And so the less airflow, the less drying, the less epistaxis. So depending on the individual, sometimes it's worse. Other individuals, it's better. I will use topical steroids. I'll use topical antihistamines also. I'll have them start with a regular spray. The majority of patients can't tolerate that, and it will lead to more bleeding. If it does lead to more bleeding and it's the actual spray itself and the force of the spray itself, what I will have them do is I will have them spray the medicine, and it's not as easy as it sounds, but try to spray the medicine 2 or 3 of the actuations of the fluticasone or mometasone or whatever into a medicine cup, and then draw up that medicine after if they can shake it down into and collect the liquid, draw it up into an eyedropper, and then have them administer in their nose in the head hanging or Moffitt's position or vertex to floor, however that you want, but drip it into the nose, and that allows for the delivery of the medication with much less force and much less bleeding. So that has worked in some of my patients to help address the allergic rhinitis and seasonal allergies and things.
Okay, well, thank you so much. I do want to keep to our scheduled time, and it is 8 o'clock. But as I close, I just want to thank you all for attending tonight's webinar. Our shared goal is to advance one common hope, to give those affected by HHT a chance for a normal life. This webinar series is just one of many ways we accomplish this mission. We are grateful to the donors of Cure HHT for making this and all webinars possible. As a physician aware of HHT, you have the ability to save a life or at least to improve an HHT patient's quality of life. Within the next 24 hours, you will receive a short survey to complete so that we can better serve you in other medical specialties in the future. Again, I want to thank Dr. Poetker and Dr. Gossage for leading this evening's webinar. Please encourage your colleagues to watch the recorded webinar and the link that you'll receive in the email. And we truly appreciate your participation. We hope you enjoy the rest of your evening and wish you all a very good night. Thank you.